Oh, okay. Is that like like danger response? Is that like making sure your scene is safe, shit like that? Okay. So yeah, essentially that's well it's the biggest inside joke of EMS that you'll ever have. Um like if you ever take an EMT class, any sort of medical class, like emergency medicine class, um as far as EMT paramedic, whatever, EMR in the US, whenever you do a scenario, you're gonna have to say BSI, PP, or PP, BSI, BSI is my scene safe, all that shit. Um, it's the same thing. I always forget about it because you're gonna do it regardless. Like I don't know why the fuck you have to. Yeah, some shit like that. You're gonna do it regardless. So I always get in trouble because I don't verbalize it or because I just do it. No, there's no exam. There is no exam. However, once we get on this class, you will be given the EMT role, whatever. Um, you'll be given the EMT role, and you will be able to function as an EMT since you're all clear or since you're all out of the probationary academy. But if we notice that you're doing kind of shitty on a truck, like we reserve the right to like bump you back down, take your EMT away, do whatever. So, shut the fuck up, Tyrone.
I'm just
Um,
cutting onions, bro. Shut up, leave me be.
So, anyways, back to your assessment after you like gather ABC. We kind of want to see what's going on, like why we got caught out there. Obviously, like you're gonna know if it's a chest pain or a sick person or difficulty breathing from the dispatch, but it's not always what they say. It could be something else going on. So, a great way to kind of help get to the point, see what's going on and why it's going on, is getting a sample history. So that's just going to be like all the events leading up to it. Um, Let me pull up the or the infographic real quick. So, sample is going to be your signs and symptoms. So, signs are what you can see, symptoms are what they feel. So, like, if they feel nauseous, that would be a symptom. You can't see them be nauseous. Vomiting is a sign. You can see them vomiting. Then we want to check on their allergies, see what they're allergic to, so we can make sure we don't give them anything they're allergic to and cause anything even worse. We want to see what medications they're on. Certain medications means that we can't give them certain medications. Um, we want to talk about their past medical history. So, what kind of medical problems they have? If they have high blood pressure and they haven't been taking their high blood pressure medicine, and now their blood pressure is 210 over 120, that's probably going to be the issue. Um, we want to know what the last oral intake, so like the last time they ate or the last time um, they had something to drink. If you get called for weakness, pretty good questions because sometimes it might be, well, they haven't eaten in 3 days and they have renal failure. So that's that's why you're there. And the events leading up to the injury or sickness. So like if they have chest pain and it just come on all of a sudden while they were reaching to grab something out of the cabinet, that's good to know. Um, so then next we want to after that we want to focus on our OP QRSTI um, sampling or questions. Um, so that's gonna be onset of the event. So what that means is, was it quick or was it slow? Or was it like slow or gradual, or quick? Just be careful not to ask leading questions. Kind of ask open-ended questions and let them describe in their own words. Don't lead them down a specific route. And then, so P is going to be provocation or palliation. So like, what makes it better? What makes it worse? Quality is going to be that 1 to 10 scale. So um, one being you just pinch yourself, 10 being worst pain in your life, you think you're about to die. You can also use that for difficulty breathing, for how sick they feel, how nauseous they are. Like you can use 1 to 10 for literally everything. Radiation or region. So, if they're having chest pain, ask them, does it radiate anywhere? Does it stay in just your chest? You know, if they tell you that it is radiating into their left arm and up into their jaw, that's good to know. Severity, uh, I can't remember what the fuck question asked for severity and time. So like, how long has this been going on? Um, it's best to try to get like an actual time, like a specific time. Like it started at 9:05 this morning. I looked at the clock when it happened, um, instead of 30 minutes ago because it might be 30 minutes ago when you get to the house, but then you're not really going to remember or keep up with the time. So 20 minutes later, when you're at the hospital, you're going to say it started 30 minutes ago. So that would be 10 minutes before you got there, when in reality is almost an hour before that. One thing to keep in mind though is OPQRST is intervention. So what have they done so far to make it better, or what have they done so far to try to fix it or make it better? Um, One thing to keep in mind though, typically it's not typically you're not going to ask OPQ or STI questions for your trauma patients. Um, Kind of redundant, it's kind of dumb. You're going to ask, what was the onset of the event? Oh, well, when I got fucking stabbed 5 minutes ago. Well, what what makes it
Do you
worse? What
think
makes
that
it
this is
better?
an EMS issue? Probably a good question to ask your stabbing patient. One thing I noticed new EMTs have a lot of issues with is expanding beyond OPQRST and sample. Like, for example, with abdominal pain, you can ask OPQRST and sample, but you're not really getting the full picture. There's good questions to ask, like, when was the last time you had a bowel movement? Have you had pain like this anytime before? Have you had any abdominal surgeries in the past? And then a lot of patients don't think about where their pain is going. So it's important to expand beyond, does your pain go anywhere else? If they have abdominal pain, does it go to your back? Do you feel it go down your pelvis? Do you feel it in your chest? I had a lady who, she was saying it was a stomach problems until we expanded on questions, asked about her last time she used the bathroom, if she was able to, eat anything, we ended up finding out it was most likely an issue with her kidneys because she just said, "Oh, my entire abdomen hurts. That must be my stomach." So a lot of new EMTs have issues expanding beyond what's on this quote unquote script. I don't know if you have anything to add to that.
No, I agree. I've also noticed a lot of newer EMTs. I don't know if you have too, but a lot of new EMTs just don't know how to talk to people. Like they're just socially awkward individuals. Um, but yeah. So so moving on from that, let's talk about vitals. So so I want to preface this with people have different normal ranges for their vitals. People have different ranges as far as they feel okay. So like if you have a type 2 diabetic, and you get there and their you stick their finger and their blood sugar is 300 and they feel fine, that's okay. Obviously it's not okay in the long run, but for them in the moment, it's okay. Just because if my blood sugar was 300 or the textbook says the normal blood sugar is 100 to 120 or whatever it is this week, it that's not the end all be all. Like their blood sugar is probably normally 300 and that's okay. Like, um, you know, my blood pressure sits typically around 90 over 70, especially if I've been running a lot that week. So, you know, if obese granny that you see walking around the buffet getting up to get her fourth plate after Sunday or on her Sunday lunch after church, if her blood pressure was 90 over 70, she'd probably be passed out on the ground because she's on three different blood pressure medications. So, we're going to talk about normal ranges. However, just keep in mind, just because you get called to someone's house for whatever reason and you check their blood sugar or you check whatever, just doing your due diligence, and something doesn't come back to a normal textbook range does not mean that is wrong. If that is not their complaint, or that is not, I don't want to say that, but like if they're doing fine, then it's okay. Like we can just tell the doctor, do whatever, tell the nurse when you're at the hospital. Like don't don't get stuck on it. Um, if you get there and it's like little old granny who's like 75 and she's like 5'2" and 85 pounds and her heart rate is 120, 130 sitting down and she says she's fine, that's a little bit different of a story. Um, because, we want to make sure that our heart is like a muscle. So our heart is a muscle. So, eventually it's going to get tired and give out. So as far as heart rate go, you know, um, I'm trying to think of the different age ranges. Um,
It's lower if you're younger and should be, or it's higher when you're younger, should be lower when you're older.
yeah,
Just say
pretty
that.
much. So somewhere around like 80 to 100 is a good like judge, like is okay. Um, obviously look at someone's like activity level. So like they just got done mowing the grass and it's 100 degrees out and they've been mowing the grass at noon and the sun's been beating on them. Their heart rate's gonna be a little elevated. Or, if they're a mall walker, their heart rate's gonna be a little elevated. Whereas if they're sitting down, it should be a little slower. Kids are always gonna be faster. Um, So yeah, blood pressure. So we want that top number to be 100 to 120. I've said 100 to 120 too much already. 100 to 120, and we want that bottom number to be anywhere from like 70 to 90. So like 120 over 80 is like the textbook blood pressure. If it's a little higher, a little lower, it's okay. I promise. Um, and
And
as
then there's also
far as
important to consider. I've seen a lot of students do this. White coat syndrome applies to every form of healthcare. It's not just the doctor's office. And white coat syndrome has been seen to elevate blood pressures, up 30 systolic. So if you have a textbook blood pressure of 120, you know, you can see a blood pressure of 150 just because the patient's nervous. Because people are nervous. I mean, if you don't understand anything about medicine, all you know is you don't want your blood pressure to be high, and people will get anxious. So something to consider.
um, so yeah, it. So sometimes you're going to be on a BLS truck. Probably, if you stay for this shift, you're probably going to be on a BLS truck. Just keep in mind, if there is the ALS resource, like me or a paramedic on Medic 22 or whatever, or there's an ALS ambulance riding around. If you get that weird feeling, like trust your gut, go with your gut. If you think you need to call ALS, go ahead and call ALS. Um, if any of those vitals just don't add up, go ahead and call ALS. You get a decent trauma, go ahead and call ALS. So yeah, we'll go ahead and finish out. We'll go ahead and finish out medical real quick, and then we'll start on the trauma, and then we'll go to scenarios. So as far as your O2 saturation, your pulse ox little thing they put on your finger, it lights up, all that good shit. So as long as it's 94% and up, so it's a percentage. So it's not going to get higher than 100%. If you see that 100%, good for you. 1 in 100. It's not that common, but if it's lower than 94% and they're complaining of difficulty breathing, let's go ahead and put some oxygen on them. One thing to be mindful of is if they're having um, chest pain and they're at 93%, don't give them oxygen just to give them oxygen, especially if they're not complaining of difficulty breathing. That can cause some more issues. So yeah. What else? Let's go over the full body assessment, the head to toe assessment.
Are they doing
So,
medications?
yeah, I guess we can. So,
Or is this like a
um,
two-part class? I don't know.
so for medications, you can only give like 4 medications.